Hello, friends. Today I'm going to discuss a topic which is very important because as a family physician, we always have to deal with the patients who are pregnant. And this topic is talking about what type of vaccination are safe in pregnancy, what type of vaccination we cannot give or should be avoided in pregnancy, and which vaccination might be given in specific conditions. So first of all, I'm going to discuss which vaccination should be given or can be safe in pregnancy or during pregnancy, that we call a intrapartum period. So there are five vaccinations which are safe in pregnancy. Number one is tetanus toxoid. Number two is diphtheria. Number three is influenza injectable form. Number four is hepatitis B. Number five is pertussis. How can we remember this? Instead of saying five vaccination, make it in your mind DPT, influenza, hepatitis B. That is diphtheria, tetanus, pertussis, influenza, which is injectable, and hepatitis B. In terms of DPT, there is one more important thing which I want to discuss here. Irrespective of the immunization status of a female who comes in the pregnancy period, what they took it in their previous schedules, it does not matter. Ideally, we always give DPT in a specific period, which is 27 to 32 weeks. This is for those who have no complications. They might be delivering in the after completing their third trimester and everything goes on smoothly. This is an ideal situation. But if you know that someone is having a high risk of preterm delivery, that means they are having a risk of being delivered their baby in a preterm period, then we should give the vaccination in 13 to 26 weeks. Okay, so this is we are talking about the one more thing is vaccination given to pregnant women should be given more than or equals to 4 weeks before delivery. Why is it so? The reason this 4-week period is the antibodies into the mother's body is going to be transmitted to the child through placenta. So we should give an enough time so the antibodies from mom to a child or infant goes, and that is around 4 weeks period. So that's why you don't supposed to say, okay, we are giving a vaccination today and tomorrow or maybe in 1 week the mom deliver a baby, they might be the baby is going to be having a good antibiotic antibodies dose in their body. So at least 4 weeks of period is a good buffer to give any vaccination, and that antibodies can be transferred to infants. Let's talk about some vaccination which should be avoided in pregnancy. Why we are avoiding this? Because they are live vaccines, and the live vaccines cannot be given to a mom who is pregnant. Number one is polio and oral. So oral polio is not given in pregnant patients. Measles, mumps, rubella. One more thing about rubella is if any mom take the rubella booster dose on a on on one day, they have to defer their pregnancy for more than 1 month after getting a booster dose. So we have to remember this 1 month period for rubella. Third is varicella, which is chickenpox. This is in the period of a varicella vaccination, the mother should not get a vaccination if they are planning to conceive within 3 months. So how can we remember this? For rubella, deferring the pregnancy for 1 month. Varicella, deferring the pregnancy for at least 3 months is the safest period option, because these vaccinations are live and they might give consequences if mom is getting pregnant in less than 1 month for rubella and in less than 3 months in a varicella case. Human papilloma virus, tuberculosis or BCG vaccination, it is a live vaccine. Shingles, influenza into the nasal form. As we know that we have said that influenza injectable form is safe in pregnancy, but influenza nasal form, it's not safe in pregnancy. Let's move forward. Let's suppose a pregnant woman is traveling to a country where typhoid and hepatitis A is common. you might give hepatitis A and typhoid vaccination to those moms. First of all, we always encourage them to avoid traveling to these countries where typhoid and hepatitis A is very common, but they have to do so. Then we can give the vaccination to them. So typhoid should be given in an injectable form, which is an inactive, but never given oral typhoid. For example, if a normal person, normal female who is not pregnant, she is going to a country and she wants to get a travel vaccination, we used to get a typhoid in the two tablet forms, which is the oral one, and they should be taking 3 tablets on alternate days. This is the normal vaccination for typhoid in a patient who is not pregnant. But if someone is pregnant, we might give the typhoid, but only in the injectable form. If pregnant woman is high risk of some conditions, then vaccination can be considered, because here benefits are higher than the risk for the vaccines. So which patients can which pregnant women can get um, specific vaccination because they are having a high risk? Meningococcal vaccine, rabies, hepatitis B, and polio. So meningococcal is, if you know someone is in contact with meningococcal infection before, or there is an exposure to that, we might give the vaccination. Number two is rabies. In rabies, there are two things. If you live in an area where rabies is common, you can get a pre-exposure prophylaxis, or if you get exposed to the rabies, you can get post-exposure prophylaxis. But we don't have to give immunoglobulins. So that means rabies vaccines can be given to pregnant moms in pre-exposure prophylactic form, post-exposure prophylactic form, but without having an immunoglobulins. Hepatitis B, I already mentioned, it is safe. If they are having chances to get hepatitis B, we can give it to. Polio, some countries have polio very common, so we can only offer injectable form of polio. We cannot offer any oral form of polio. So three things remember: polio in injectable form, typhoid in injectable form, and influenza in injectable form, because all the injectable forms of these conditions are having killed vaccine. So that's why. Let's talk about vaccination we have to give after completing their pregnancy period. That means the mom is in postpartum period. She has delivered her baby. Now, what type of vaccination we might give to the number one, rubella. As we already mentioned that we cannot give rubella in pregnancy even 1 month before they are conceiving. So that means we have to give rubella after completing their pregnancy in a postpartum period, and this should be given to all the non-immune mothers, those mothers who does not have their immunity with the rubella before. Hepatitis B, if you give it to mom, that's okay, even though you give it or not, but you have to give it to the infants. There are some specific conditions in which we have to give it to the infant. Is number one, their mother was unknown for hepatitis B infection or she was positive. Then, or if father was a chronic hepatitis B infectious person or patient, we have to give it. Hello. So we already discussed about hepatitis B in to be given in infants, when they are given, when mother is unknown or she is positive or father is having a chronic infection of hepatitis B. And what are the doses we used to give? We give 3 doses of hepatitis B to the infants. One you give at birth, then you come the patients come for the follow-up in 1 month, you give second dose, and after 6 months. So these are the 3 doses should be completed. Delay in postpartum vaccination if patients received immunoglobulin or blood product, that means packed cell RBCs or RH immunoglobulin. So sometimes we cannot give immediate vaccination in postpartum period, but if mom has received any immunoglobulins or any blood product, so that's why we might give a delay to that. Let's talk about post exposures. Post exposure of measles in a non immune pregnant woman. Risk of complication due to measles is very high. Then we have to give IV immunoglobulins within 6 days of exposure. So take it as simple as, if pregnant woman, she is non-immune with the measles before, she was exposed to measles, for example, she is a daycare educator, the kids in the daycare are having measles, she is in a healthcare professional, she saw a patient who is having measles, so that means she got exposed to the measles, but she is non-immune. At the same time, she is pregnant. Definitely measles risk are very high in pregnant women, so we should be giving injectable form of immunoglobulins within 6 days of exposure. It is very important to remember the word 6 days of exposure into terms of measles, but to those women who are non-immune. We are talking about second condition, which is varicella zoster, chickenpox, and it is about post exposure. Pregnant woman non-immune exposed to chickenpox, post-exposure prophylaxis should be given, that is varicella zoster immunoglobulins, between 72 to 96 hours of exposure, but maximum buffer is 10 days. For measles it's 6 days, for varicella it's 10 days, but the best period is 72 to 96 hours. And it is also given to pregnant women who are non-immune with any varicella vaccine before, and during postpartum period, at least 5 months after, in postpartum period vaccination for the varicella, we should at least give after the 5 months of recipient of immunoglobulin. That means they got exposed during pregnancy, they got their immunoglobulin, they delivered their child, now they have 5 month periods of buffer to wait before you give any varicella vaccination to them. So this is all about varicella. Why I'm talking about varicella so much? What is the reason behind it? There are some complications which are very significant. If pregnant woman non-immune exposed to varicella virus, and we need to give the prophylaxis or no. In maternal complications, encephalitis, pneumonia, fetal complications, pox-like rashes can be present, pneumonia, encephalitis, bacterial superinfection on rashes. On the rashes, superimposed bacterial infection can happen. So these complications can be avoided if we give an immunoglobulin in a post-exposure period, that is 72 to 96 hours. So this was all about the today's topic. I hope you guys like it. If you have any questions, any feedbacks, I'm more than happy to hear. Thank you so much and have a great